about mental health. I'm Nels Kloster. I'm an addiction psychiatrist.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor and licensed mental health counselor. Good evening.
Yeah, I want to remind people to send their questions to us at our Facebook site or at our email. Our Facebook is facebook.com / Let's Talk VT, and then our email address is questions@letstalkvt.com.
So, with your patience, I'd like to mention something that happened this morning. I was reading the New York Times, and the sports section had one, was a blank white page with one story in the middle of it, and which was almost like saying, you must read this. Right. You know what I mean? If you read it, you must read this. Here is this one story. And it was about a young man in Pennsylvania who started playing football very young. His father was a coach, and he was a very aggressive player, you know, loved to hit players, and went into college, I guess junior college. But what the story was about was, as he got older, he began to show some symptoms of that concussion syndrome that they've been talking about. And one of the reasons I'm mentioning this is that his behavior started becoming erratic. He also, they said something about him using substance abuse, started to abuse substances and prescription meds and things like that. And so a lot of people were sort of, I guess family members were concerned about him, like what was happening to him. And this was a football family that sort of grew up in the Pennsylvania football is everything.
Right.
You know,
sort of a Pop Warner, yeah, Pee Wee, all the way through high school.
And you know, it was very tragic. It was a very sad story. I mean, he ended up, you know, committing suicide and stuff. You know, and one of the things I was struck by was, you know, it's like watching I guess, I don't know if this is fair, but almost like a train wreck slowly. You know what I mean? Everybody could see that this young man was in trouble, did sort of strange things that were well-meaning on some level, but really, you know, should have been warning signs. And everybody sort of saw it, but sort of missed it too. Anyway, I just want to mention that, and I guess what I'm thinking is that, you know, if you if you know somebody in their 20s and their character and almost their personality changes, and they begin to do things they wouldn't normally do or something like that, you know, don't just rule out that it's like bad behavior.
Right.
You know, maybe there's a medical thing. Maybe there's something else going on.
Yeah, I mean, that's classic advice too, when you're diagnosing someone in psychiatry, that you want to first rule out medical causes or rule out the drugs are playing a part of that. And we're seeing a lot of attention to traumatic brain injury in sports. I know a lot of attention with girls in soccer and all those sort of the impacts of the ball in their head from you know, greater and greater distances. And you know, one of the issues with these injuries, I'm sort of looking at the anatomy of it, they talk about what's called coup and counter coup, or sort of hit and counter hit, in that, say example, when there's a force to the front of the head, whether it's a soccer ball or somebody else's head, or, you know, head-on collisions, or motor vehicle accidents as well, is that the head gets sort of stopped moving forward, and the brain, which is sort of engulfed in fluid in there, floating around in the skull, then gets sort of pushes forward, and then so the frontal lobe then compresses in the front, and then it's sort of then bounced back, so then the back of the head, or sort of cerebellum area is, and the vision centers are, then hit back there. So you, with those hits would seem to be the front, are actually damaging the front and the back of the brain. Yeah,
there's a column in the essay or story, whatever, in the New Yorker last week, Oliver Sacks, and he's having his own health problems, but he's writing about somebody who's in a car, a famous author, I think, an actor, a screenwriter. I'm not acquainted with the man, but the same thing happened. He was sitting in the back seat, and the car accident, he ended up hitting his wife's head, who was driving, and he had tremendous depression and all kinds of problems, and ended up, again, dying from it. But Oliver Sacks, as you know, writes about these things, and he wrote about what happened to him.
Yeah, and like you said, I mean, memory changes can happen, headaches, obviously, you know, personality changes, impulsivity, irritability are symptoms to look out for, and those could be short-term or you know, long-term symptoms. But definitely paying attention to this. If you've been knocked unconscious, consider you have a concussion, potential injury, and you know, rest, but definitely get some attention to it.
Yeah, and it's, in a way, it's really good. I was playing with a grandson, and they put a helmet on him right away because he was, first time out on a bicycle and everything. And I thought it was really good. Normally, like I bet 20 years ago, I would have been,
There's
helmet,
going to be some social change around this because now parents are starting to reconsider whether they want their sons, in this case, playing a game of football before high school.
Right, and what you're really looking for is you want to go from like it's cool not to have a helmet and do roller skating to like people saying, well, that's dumb.
Yeah.
You know what I mean?
Peer pressure.
Really, like, well, that's dumb, that's one thing, but you really don't want to.
Yeah, public health and peer pressure is what it's all about.
That's right. The other thing, speaking of peer pressure, and I saw it in the news, was, and we talked about this, I think, about 3 weeks ago, maybe a month ago, e-cigarettes. Mm-hmm. And the good news is that tobacco smoking is going down.
Right, because people are using these to quit smoking.
I mean,
cigarettes.
significantly, the numbers statistically have gone really down. But on the other hand, e-cigarettes or nicotine delivery systems, whatever you want to call them, has jumped dramatically. Okay. And it now turns out they think that teenagers are not smoking cigarettes, but are using these e-cigarettes.
And then they could get hooked on nicotine in that way by the vapors from the e-cigarette.
Sure. And it's still money. And I mean, one of the fundamental rules of selling addictive drugs, whether it's alcohol or nicotine, is get them young, make it easy for them, glamorize it if possible, and then you have them for life.
This is reminding me too of diet sodas. They come out with sort of lower calorie sodas than the full tilt sugar ones. And what they found out is that people who drink diet sodas drink more of them. So that way you're maybe getting the same or even more sort of total calorie intake, because I think each one is less harmful and they don't realize the accumulated effects, because each time they drink it they're saying, oh, this is okay, this is better than the full tilt Pepsi or Coke. I'm drinking diet, and they don't realize that they have that thought every single time, and that it accumulates to be actually more calories, and then having them gain weight instead.
And one other thing that last week, 3 weeks ago, I think you did a great job talking about treatment for opiate addiction. And I've got comments about that. People were sort of really pleased to hear what you had to say about it. And one of the things that we're talking about, or have been talking about, is this idea of doing a public forum on opiate addiction in our community. And not really, well, I don't know if this is the right way to approach it, but just this idea of, like, for people who are interested, people who may want to come and find out and ask questions, and perhaps we can find a space downtown. Maybe make it part of one of our shows or something, but really put it in a place where people can find information about Narcan, needle exchange, or whatever else that we can do, the sort of possibilities for treatment, approaches to treatment. Maybe we can do that for them in public, because I think there's a lot of people in the community who are sort of may have a loved one who is struggling with addiction right now, or they're sort of concerned, or they want to just find out about what's going on. I mean, one of our questions that came in that was that we're going to talk about in a little bit here, what is this about this epidemic? What can we do about this epidemic? So maybe we can talk about that, and I'm thinking of planning on doing this, or we can do this together sometime in the beginning of June.
Yeah, because we had a forum in Bennington along these lines, and one of the things that I noticed is that so many people have no idea where to go, where to get information, who to turn to, what's the right level of treatment, once they get over the sort of the shock of realizing that someone they love is injecting heroin, for example, or crushing pills and snorting them. So the idea would be, it's sort of a basic education around where to go and what to do.
Okay, and you have your own public...
Yeah, and I want to sort of look like a public service announcement.
That's right.
I work over at the methadone clinic here in Brattleboro at Habit Opco, and we had some representatives from the state with us today about a pilot project for Narcan. Now, they've been doing this throughout the state. They started up I think in Rutland and Burlington, and it's been moving its way down south. And so now finally we're going to have this program as a pilot here in Brattleboro. And the idea is, again, this is an antidote to reverse overdoses from heroin or other opioids. That it's Narcan, or naltrexone is what it's called, And we discussed this with previously. It's simply, it knocks the heroin out of the opiate receptor and takes its place, so that for a while the heroin can't get back into the receptor, and in that way you reverse the overdose, so people start to breathe again. And I just want to let people know that we're going to go out in the community with this, but if anybody is concerned, has a loved one that has experienced an overdose, or they're afraid they're going to overdose, I would just suggest give our clinic a call. The number is 258-4623, and we'll keep you informed about when we're going to start going out in the community with these things. But we're at a point where very soon now we could be handing out these overdose antidote kits, and they've used these throughout the state. They've had about 140 incidents of these being used, and it's a very important treatment to save some lives and hopefully get some people back to get their life back together.
Oh yeah, and I don't know the current statistics for our state or any one state, but I do remember reading in the Boston Globe about the number of people ODing, and it was like the #1 cause of death for young adults between certain ages. I think that's true. I mean, and there was this story about people getting dropped off at emergency rooms, or then they passed a law said, if you bring somebody to an emergency room, you won't get prosecuted or something. But they were trying to figure out, you don't want someone to die just because they got high. Right. I mean, quite frankly. And so, and then I understand rescue and the police and the firemen were starting to bring Narcan. But I think what you're saying is that, they want to be able to reach people who don't call 911, who don't reach out.
Right. So, it's a very simple kit. I mean, it's color-coded. It's about 3 steps. And you don't have to have any kind of professional background in this. So I think that's the key thing here, is that if you're concerned.
How is it administered?
It's through the nose.
Okay, so it's just
it's through the nose. So you put the vial into the sort of the syringe, and then you can vaporize, just shoot the vapor up into the nose and the membranes in the nasal passages, and absorb it into the bloodstream.
Okay.
And then you can reverse the overdose. And like you said, the idea is not for us to put this in doctors' offices, schools, emergency departments, but rather into the hands of people who are outside of those services, who have direct contact with somebody who might die from an overdose.
So that might be something that we could also do at this forum, and make sure we get it out there and get people to use it.
Absolutely.
Now, is there any concern? And I have this concern. I mean, is it get to a point where we say you don't have to worry about shooting up because you have Narcan? In other words, you've been able, and I don't know if that's legitimate or not. I mean, people do want to get high right up to the point of nodding out. I mean, almost being unconscious to enjoy it. But I don't know if that's a legitimate concern. But the other thing I mentioned to you before, and I hope you can say something about it, is some people may think that they can do this in lieu of getting a medical help for the individual, and that they should still follow up.
I mean, it's really concerning, because the statewide percentages around this show that maybe 30% of people who've used these kits have actually called 911.
So 70% did not.
So 70% are just using these inhaled Narcan kits, and not going for further medical attention.
That's a bad idea.
Well, it's definitely a bad idea. If you've gotten to this point, you really do want to go and get some medical attention. But I think too, when you realize how people are not going for medical follow-up after these, it strikes me as making it even more important that these are out there, because these are people that really would be left for dead otherwise.
Right. Now, we got a question, and I suspect this is from an old-timer.
Okay, sounded like it.
It sounded like it. I disagree with drug and alcohol use as a medical problem. And then it's a choice, exclamation point. Why call it heroin epidemic or alcohol disease? And I guess, we've talked about it being a medical problem. But, I think he has a point there about epidemic, and that, when I asked you about this, and you were saying, well, it doesn't have how did you say?
Well, it just doesn't mean, it's bad English. It's bad word choice to call this thing an epidemic, because epidemics, the idea is that, for example, some kind of infectious agent.
There you go.
Like the flu, those sorts of things. And it has sort of a starting, and then it sort of gets communicated to many people in the community until it reaches such a point that, like say with polio in the past, before vaccinations, that people started to die from these things. Flus even have killed people in the past. Right. And so the idea is it just sort of like wildfire, it sort of catches and spreads, and the next thing, kind of states or countries are wrapped up in this. Now, not to take away that this is a problem, right, but it's not like that if you're a heroin addict, it's going to rub off on me, right? That I can't breathe the same air. So it's a very dramatic word, though, right? If you talk about an epidemic, that gets everybody's attention.
Well, and I think that's part of it, is that it got everybody's attention at the same time that we had a heroin problem in Vermont. And people were abusing pills. I mean, people were snorting them. I mean, oxys. The whole thing was going on for years. I mean,
this is not new.
But it's interesting. You used the example of a flu. I mean, I think when they saw all these young people or people who were using in withdrawal and being dope sick, and I remember at one point. We used to bring people down from Burlington all the way to Greenfield, Mass. To get methadone. I mean, we had people riding back and forth just to, because people said, I need help with this. And, the state of Vermont decided, we can allow for methadone clinics. And then, they increased with the Suboxone treatment. They set up things for that. So I think there was a gradual, I wouldn't even say gradual. I guess it was a rapid.
Well, we had a sudden awareness of this, right?
Right, and then it looked like everywhere we turned, there was opiates. In every hamlet, every little place, there was people using opiates.
Well, it's like, and you said once, too, that you met your first heroin addict like 50 years ago?
Yes.
Right, in your neighborhoods there, and so these things, again, opium, thousands of years this has been going on, and it waxes and wanes, it rises and falls as far as how many people are involved with these things. But then also when you learn of something, when you notice something, like when you learn about homelessness, you learn about addiction, or you learn about these sort of traumas, then all of a sudden you become attuned to it. And then all of a sudden you can pick it out.
Right.
I mean, addicts, for example, they'll tell you to drop me off anywhere in the country blindfolded, take me to the bus station, and they can point out people just by their sort of their demeanor, maybe they're strung out in their withdrawal, because you develop an awareness for this thing. And maybe that's where this term epidemic is really coming from. Is also suddenly people are aware of it and then realizing the enormity of it, the impact of it, and finding that this very flashy word is exciting more attention about it.
But it's not one thing. I mean, I was talking to somebody that says a lot of what we're doing now is trauma informed. We want to be aware of trauma, and I think there are people out there that say, you want to be aware of poverty, the impact of poverty. You want to be aware of any number of factors that seem to contribute to different things, and that's why sometimes I get a little upset when I hear somebody thinks that the solution is to give somebody, just one thing. Like we'll do this one thing and this will make it right, because it's really a much more complex thing. I mean, there's housing involved. You're involved with housing.
Right, like pathways to housing, right?
Pathway to housing. There's jobs. One of the things that we know, number one thing that helps stop people returning to prison is employment, quality of life issues. So there's lots of different things. It's not just one thing. So.
Yeah, and even though we're seeing more people drawn to opiates now, seeing them come from sort of not coming so much from impoverished backgrounds, I still, the majority of people that I see are coming from either economically or socially deprived backgrounds, trauma, poverty, lack of education opportunities. And again, we all have the same drive. We want sort of, the happiness and purpose, and want to feel good. Right. And that's maybe sort of the hook. So the idea of sort of a disease really almost sort of narrows it to very sort of medical sort of problem.
Exactly.
It, equating it with, again, like we're talking about epidemics, things you can sort of catch and pick up, there's sort of a quicker cure for or treatment for. But a much larger, bigger problem that requires more medical intervention.
We'll talk about that when we come to your question. I just want to finish this, because he did mention disease as alcohol. And as far as I know, the history of it is that when they started talking about it as like AA talked about it being an allergy, but the idea was to move it away from being a moral problem.
Yes.
And try and make it more of a medical model, medical problem. And And they said arbitrarily there's these characteristics of a disease. It's chronic, it's progressive, and ultimately untreated, it's fatal. And if that's the criteria for a disease definition, then you can use it for alcoholism. Because it is a chronic illness, it tends to get worse, and left untreated, people die from alcoholism. So I think that's how it is, but when you hear people talking about whether or not it's a disease, like this man, he's saying, I don't think it's because there's a choice involved when people use drugs or alcohol. They make a decision, and I think in some ways that's why it became diagnosed as a mental illness, because you see cases where people don't want to use anymore, but they seem unable to stop. They no longer have control, and there seems to be the AA calls it as obsession. A physical compulsion and a mental obsession, and that does seem to be true. And once you develop withdrawal symptoms, it sort of feeds on itself over time. You need the drug just to sort of be normal, just to sort of get about your day. And so,
and there's often a component of choice in this. Of course, you have to sort of choose to get help. You have to choose to take a path away from it. But it's so much more complicated. If you look at sort of one pole of this, it's a disease, then what a lot of folks say, well, I wouldn't blame you for catching the flu. So you're completely off the hook, absolved of any sort of personal responsibility. Whereas if I say it's a matter of choice, then that can usually be very stigmatizing and a condescending sort of attitude.
But I wish we could join somewhere in the middle. There is a responsibility, there is choices about getting better, there are choices about what you can do not to get started.
I think the middle path is usually the better path, right?
You know what I mean? Like, I don't want to shame them, I don't want to stigmatize them, if you will. I don't want to give them an excuse that, I got this illness and everything, that's why I use. But at the same point, I don't want people making assumptions that they're morally corrupt or they're bad people or anything like that. I mean, we have some thoughts that genetics are involved and some other issues are involved. So, yes, it is a choice. Yes, it is. People can choose to get better. They can choose not to use in the beginning, when they first get an opportunity to use. But at some point, it obviously crosses over into something that is a public health concern, if you will. Individual health and public health, or whatever way.
Right. There's so many ways. There's so many ways to look at this, and please don't look at it in a simple polar fashion. It's either black or it's white.
There you go.
All right.
You're very patient with me.
That's you bring up good things. So then we do have another question. My son got a prescription for oxycodone for a broken arm, and I'm afraid of him becoming addicted. Is there anything I can do? So this, of course, there's all this fear these days. There's this idea too that some substances are so potent that if you even try them, you sort of open a Pandora's box, right? You unleash the beast in some way. And again, we lose track sometimes of the fact that these are very sort of powerful but effective medications as well. And used appropriately, they can have great benefit.
Well, the public, they've done a pretty good job with education. I remember those ads they had on TV about the biggest risk is, that leftover meds that's in your medicine chest. You know what I mean? The kids know what they are, and and they have these programs like here in the police station downstairs. You can drop off prescription meds, and you can,
and the sheriff's departments in other towns are doing this too.
Other towns have them. So, in a way, I'm sort of happy that question's being asked. I mean, you can sort of explain it more, but I like to have people sort of concerned that I'm bringing opiates into my house. Opiates are a dangerous drug. They're a very powerful drug, and they shouldn't be treated lightly. And I'm just so glad that people are paying attention to it. And you've heard me say before, I think one of the problems we had in Vermont was that people were sort of naive about doing opiates. I mean, if you grew up like where I grew up, and we knew heroin addicts. We knew what it looked like. We knew what happened to ball players that did heroin. I mean, it was pretty, it's no secret. I think in Vermont, in some ways, people were very naive about doing opiates. Thought that somehow, well, it's just like any other pill.
Well, and I
or
mean,
anything.
nationally too, there's this idea that if a doctor prescribes it, well, it must be safe, because you know, a doctor wouldn't prescribe something that wasn't safe, which then takes, just like we talk about sort of legalization of marijuana, that gives a false sense that oh, it must be safe because, well, for example, doctors prescribe that in some places. They prescribe the oxycodone and stimulants, and thinking then that when it's offered sort of off the cuff, not by you know, family or a friend, you're like, oh, it's a prescription medication, it must be okay.
Right, and I've seen ads in or an article in the paper one time, the signs saying on a drugstore, we do not have opiates, or we don't have this or that. And I've actually seen a story where somebody says it's become so difficult now to get treatment for pain. Certain doctors won't write scripts for this and that. So I think in some ways it's a pendulum. Like everybody was getting them, and now there's a concern. There's a woman here who's concerned.
Well, but then there's there's an attitude around this too. I mean, Americans consume, I think it's like 90% of the hydrocodone or Vicodin that's prescribed for the entire world. And part of what's been an issue with this is that therefore that diverts us, say, from poorer countries where people would benefit from this for, say, you know, surgeries or serious accidents. So there's sort of inequity here and a social attitude around this, and hopefully as we develop awareness, people are realizing, oh, you know what, opiates aren't required for most pain conditions. Ibuprofen is a good medication, supportive care, you know, ice, heat, that sort of thing. But I want to make sure we don't forget to give some advice here too, because it's absolutely, I mean, we don't know how old this son is, but I would be concerned if there's already some drug experience. You know, if there's been intoxication with alcohol, if you happen to know that this child smokes marijuana. One of the things we look out for when you talk about starting a prescription for opioids is looking for various risk factors. That's what we're starting to talk about now with the education about decreasing the prescribing of opioids. And what you want to look out for is sort of family history. Like we said, half of this we think is the genetic influence for people who become addicted, and look for experimenting with other drugs as well. Also, you want to be aware for what we call sort of reinforcing effects. Does your son really, really like this prescription? In that case, you want to be very careful about it. Again, don't give it to your child to control. You're the adult, regardless of what the child's age is. You need to keep track of this prescription. How often is it supposed to be given? Is it disappearing, or are the numbers in the bottle starting to deplenish too quickly? In which case, then start to think, whoa, you know, we're playing with fire here. So, you know, family history, you know, increase in need or use of it, and a previous history of you know, drug experimentation would suggest that this is you know, potentially a problem. It doesn't mean, though, that people who have the potential for addiction or people who struggle with addiction should have to experience excruciating pain.
Right.
It just means there needs to be a different level of control and a more cautious or prudent approach to the prescribing.
Thank you. And that's good advice for even addicts who are grown and who are in recovery. You know, I don't want them to suffer thinking, oh, I can't possibly. It is dangerous, though.
Right.
A number of people, when I was working in the hospital, came in and they relapsed, getting a prescription, and they thought they could get away with using it and having it under their personal control, and they were unable. Now, granted, when I'm in a hospital, I always see the ones who are unsuccessful. Right. There might be other people who were able to use it, but it is a very dangerous thing. Do you mind if I close up here? This is the end of our season. It's been a great season. It's been great having you. 3 seasons? Yeah. And what we'd like to do is we'd like to ask people, once again, if you have any suggestions, you know, especially for next year, if you'd like to see us do something differently. We talked about interviewing consumers. We've talked about taking some different approaches. We did have some guests on this year. I thought that went well.
Oh, I always enjoy having guests come on board for different perspectives.
That's right. So again, if there's anything at all, like I said, we're going to try this public forum on opiate addiction here in town. Maybe we can do some site visits if people have some other ideas. I mean, basically what we were hoping was this program, you know, just like BCTV, is what's the best way to use the TV? How can we use community TV most effectively? By the way, BCTV right now is doing a research, if you will, reaching out to people to find out, is there a way that you can benefit from using BCTV in a more effective way? Please call the station if you have any ideas.
Yeah.
Let us know.
Thank you.
Thank you.